Hi everyone. So welcome. Today we have the privilege to have Professor Amy Cohen from University of Michigan as our Jones Seminar Series presenter. So Professor Amy Cohen, a little bit of introduction about her. She's a Thurnau professor at the University of Michigan. She's an associate professor in the Department of Industrial and Operations Engineering, and she's also having an appointment in the School of Public Health there. And also, she's the Associate Director of the Center for Healthcare Engineering and Patient Safety. She's also an affiliate of the MIT Global Airline Industry Program. Her research interest is in applied combinatorial optimization in healthcare and aviation. And she received her PhD in operations research from OR Center at MIT, and also her AB in applied mathematics from Harvard University. So please join me in welcoming Professor Cohen.
Okay, thanks, Vikrant. So can you hear me in the back? Can you hear me too much in the back? That's usually where you go to sleep, right? Am I going to keep you awake? Okay. All right, I know where to find you. So thank you, Vikrant, and thank you all for having me here. It's the last time I was at Dartmouth, I was looking at colleges when I was about 16, and so it's as beautiful as I remember, but it's nice to be back. I'm going to talk about challenges and opportunities in scheduling healthcare providers, and I know this is sort of a diverse crowd, and so what I've tried to do is prepare a talk that hopefully will have something that's at least a little bit interesting for everyone, that's not going to be too deep methodologically, but for those folks who really want the deep methodological stuff, we can do some at the end over, if someone saves me a brownie, I will save them, some proofs or some mathematics. So as Vikrant mentioned, I'm Associate Director of something called the Center for Healthcare Engineering and Patient Safety, and I've been talking with some of you about this and this notion of multidisciplinary work. And so I wanted to have a couple of pictures just to give you a sense for our group. This summer, I think I have about 35 students who will be working with me, ranging from our PhD and postdoc, masters, and undergrads in industrial engineering, but we also have 3 nursing undergraduates, 3 pre-meds this year, 2 medical students, a couple of residents, some computer science students, all working together. And I think that, and it sounds like to some extent part of what I've heard today about one of the nice things going on here, is that you have this diverse group of people who are doing very different things, working in close quarters. And so that's something that I find really exciting. The mission of CHEPS is to improve, you can read this, to improve safety and quality in healthcare delivery. The focuses are multidisciplinary, systems-based, collaboration. So the idea is really, it comes from the notion that there are all these engineers, industrial engineers, but I think engineers in general, with our hammers walking around kind of looking at things that look like nails, right? And that looks like a nail, and I'll start hammering away at it. We've got clinicians who have problems and who have no idea that these tools exist. And they'll say, no, I don't have any nails. I've got sharp, pointy metal things, but no nails. And so a lot of what we're trying to do is find a way to bring people together to understand what the problems are, and then to try and work together to solve them. And then perhaps the most challenging part is how do you actually implement these solutions? So a lot of what I've been doing over the past 4 years has been developing educational programs. So we've created a concentration in our master's program where the students not only do the traditional engineering work, but they also do networking activities with people in the health system and seminars, and they work on year-long projects. And what we found was in forming this master's, in order for the master's students to work with clinical students, the clinical students had to work medicine with pediatric components, and trying to do is understand the space in a way that we can then help others and broaden the reach of solving problems in a way that actually has impact in practice. Okay, so the work that I want to talk about today is primarily sort of the near and dear methodology area that I care about, which is scheduling. And I did a lot of work and continue to do some work in scheduling in aviation. And there's a lot of concern, I think, where people say, well, but you can't take manufacturing and apply it in healthcare because patients aren't widgets. Or, scheduling airplanes is totally different from scheduling doctors. And there's a degree of truth to that. And I think it's really important to be sympathetic to people's concerns about that. Ultimately, they're responsible for patient care. At the same time, there's a lot methodologically that really does transcend. And so it's been interesting for me from an impact standpoint to see how some of the stuff that I love to do in scheduling can actually impact practice, but also from a research standpoint to see where are the commonalities and where are the differences. Okay. Vikrant, your job is to watch time because I can barely see that clock, and you know I'll go on forever. So you just give me a cough at about, now we go to 6:30, is that right? Okay. Okay. I want to acknowledge my collaborators, primarily the PhD student, Young-Chae Hong, but we've had the pleasure to work. So in working with scheduling residents, you work with the chief resident, and that's a yearly rotating position. So this is now our 4th chief resident that we've gotten to work with. Billy and Zach are just 2 of the students who are working in detail on this project. And I want to acknowledge all of the funding sources that have been helping us with this. But let's talk about residency, okay? So one of the challenges of scheduling residents, and it's interesting, depending on who you talk to, I've had people say, oh, scheduling residents is nothing. That's easy because they're sort of worker bees. It's things that's hard. I think to a large extent, scheduling the residents is harder because there's this dual role. So residents provide patient care, right? For those of you who aren't sort of familiar with the medical system, when you finish medical school, you go off and you take care of patients. So let's think about it. There's a moment where you were a student, and there's a moment later where you're a thoracic surgeon. And that's a kind of a scary thought as a patient, right? So the whole medical model is really built on this, see one, do one, teach one, where as a resident, you start off by doing a little bit with someone watching very carefully over your shoulder, and you get progressively more and more independent, and you do work more and more independently. So residency has these 2 roles. On the one hand, it's part of medical education. You are learning about how to deliver care. And at the same time, you're providing patient care, right? So I take my kid into the emergency department for some stitches, and it's a resident who does it. I don't care that you're a resident. I don't care that you're getting a learning opportunity. You either do it well or you don't, right? So we have to meet both of those needs. So as a resident, I might be doing continuity clinics. A continuity clinic is a clinical, like a primary care environment where you see patients every week over the duration of your entire residency. So the notion of building up this continuity of patients. But in addition, you might spend a month, so if you're in pediatrics, you spend a month in hem-onc, so hematology oncology, basically childhood cancers. You spend a month in inpatient. You spend a month in emergency medicine, which is what I'm going to be talking about. So in any given month, in addition to your clinic, you're now doing service within this particular field. You're doing seminars and other educational activities. You might be doing research. So all these things have to fit together, okay? When you think about staffing residents, you've got all this complexity like you do in staffing in any environment, plus this whole second level of sort of this dual notion of training. So there's the impact of patient care in the short term, right? Who am I seeing today? If I'm really fatigued and I'm trying to figure out your medication dose, that's potentially a risk of harm, okay? So one of the is the ACGME, which is sort of the ABET of medical education. They're the accreditation board. They said, you know what, residents are spending, residency comes from the word residence. You used to live in the hospital. You would come to the hospital, you would live there during your residency, but you might also be working for 36, 48, however many hours straight. And so at some point people came along and said, you know what, residents aren't getting enough rest, and it's impacting patient care. It's also impacting their health. There are some really frightening statistics, both residents and when nurses work long shifts, about the accident rate of people driving home, right? So there's this impact on short-term care, the patient, but also the resident themselves. But there's also this long-term care issue. So one of the other projects we've worked on is with a thoracic surgeon, looking at how you train residents to prepare to do heart transplants. And they arrive randomly, right? And they arrive at crazy hours, and they take about 30-odd hours to go through the entire process from the first phone call to actually completing the surgery. But you're not supposed to be on call necessarily during those time periods. So how do we make sure in the long-term sense that you have this continuity of care, but also exposure to lots of different clinical experiences when these experiences are sometimes rare? And then finally, there's the impact on the pipeline, right? So there's a degree, we hear a lot of when I was a boy, we walked uphill barefoot in the snow both ways, and when I was a resident, we never got to sleep, and da-da-da-da-da-da-da-da. And that's fine, and there's a degree to which the process has to be difficult, in part to prepare you for what it's like when you're working in the emergency department as an attending, and the bus accident comes in. Like, you need to be ready for that. But there's also a point where you realize that people say, you know what? I could do 3 more years to train to be a transplant surgeon, which also means I'm going to go work in a teaching hospital, or I could make more money going into private practice as a thoracic surgeon who doesn't do transplants because this process is arduous. I can have no family life. I would like to make sure that you can have a heart transplant. If you're hoping, Reed, that you never will, but if you do, we want there to be a surgeon who's trained. Okay. So we have these inherent time conflicts, right? We need adequate coverage with a limited pool of residents. So CMS, the Center for Medicare and Medicaid, says your teaching hospital can have 35 pediatric residents. You can't say, you know what, we're willing to put more money in because we can't staff at that level. We need more people to have more flexibility for staffing. This is the pool that you get. So you need to cover all of your, in the case of the emergency department, you need a body there, right? You need a doctor there at all times. You need opportunities, you need adequate rest, and you need to have some level of concern for the residents' well-being. And it's not just the quantity of hours that they work, it's the pattern. So there's this issue of continuity of care. On the one hand, I don't want you so tired that you're making mistakes. On the other hand, if you're the doctor who's been treating me, and now it's time for you to go home, and you sit down and you say, okay, Brian, this is what I've observed with patient Vikrant, and this is what's going on. There's going to be something lost in that information exchange, right? Every time you hand off a patient, you increase the risk a little bit. Okay? And there's sleep issues. Perfectly legal, according to rest rules, for you to work a shift that starts Monday morning, so work during the day on Monday, and then work an overnight on Tuesday, and then work a morning shift on Thursday. You get your between every shift, perfectly fine. It destroys your circadian rhythm. It's a terrible way of scheduling. Okay, so we've got to care about these things. All right, so here's our problem. I have a set of residents that I want to train. I have a set of shifts that need coverage, and I want to build a schedule so I satisfy patient care needs, I satisfy educational requirements, and then I've got this other stuff like resident satisfaction. In particular, the project I'm going to talk about is the Pediatric Residency Program at Mott Children's Hospital. So the University of Michigan has a standalone children's hospital which has its own pediatric emergency department. Within the residency, so residency is tricky because you've got pediatrics, right? So I'm doing my residency in pediatrics, but one of the things I have to do is spend some time in pediatric emergency medicine. You're doing your residency in emergency medicine, and as part of your training, you have to spend some of your time in pediatric emergency medicine. You're doing family practice, you so on, emergency medicine. So we've got somewhere between 2 to 5 programs in any given month that say, here's a body of people who are going to spend the month on rotation in pediatric emergency medicine. We have 7 shifts a day that overlap, so they're staggered shifts. We are open 24/7, 365. Every shift has to have a resident. Oh, except there's a flex shift. And in fact, I think these slides are already at some point the flex shift became 2 flex shifts and then it was back to 1 flex shift. But basically you have shifts that don't have to be covered, but you can use them if you want to make sure your residents get enough shifts, but the attendings aren't happy if you don't cover enough of them. But no one's ever really been able to quantify how many is the right number. Certain shifts can't have an intern. So interns are first years. So they've really never touched a patient before, right? If you're a second-year resident, you did emergency medicine last year for a month, you at least know where to find stuff. Interns cannot do the busiest shift of the day. There's some shifts where one of your residents on these 2 overlapping shifts has to be pediatrics, and this list goes on and on and on and on. Now, by the way, if you've ever worked in aviation, they'll give you this list, right? If you think about the crew scheduling rules, they'll give you a book that says these are all of the rules. There's no list anywhere. It's you build a schedule and someone says, oh yeah, I forgot to tell you, you can't put an intern on Tuesday afternoons. So we have this long list. Oh, and by the way, when you build the schedule for October, you don't want on October 1st at 7 a.m. for everybody to be brand new. So what they do is the interns start on the 27th of September. So when you build the October schedule, you also have holes from September that you have to fill in. So you better hope that you have enough bodies in October to fill the things you left behind in September. But you're going to leave some holes at the end of October, and then in November you're going to have to worry about that problem. Residents do get vacation time. They get a certain number of vacation days over the course of the year, and it gets pre-assigned, and there are only certain times that you cannot take vacation during that month. In advance, like a year in advance, that the first 2 weeks of the month you're on vacation, and the second 2 weeks you're in the emergency department. So those days you're out. I can't schedule you. You have your continuity clinic. So your continuity clinic is every Tuesday afternoon, yours is every Wednesday, yours is every Wednesday, yours is every Thursday. Not only can I not schedule you during your clinic, but I can't schedule you prior. You need to have at least 10 hours of rest before your clinic and 10 hours after. We have this 10-hour rest rule. I might be coming on from nights. So if I'm working nights in October, I can't work the 7 a.m. shift the first day of November, and on and on and on and on and on. How do these get built? You take a kid who's really smart and send them to med school. And they're at the top of their class in med school, so they get into their first choice for residency, and you take the best resident and you say, you're such a great resident that we're going to ask you to stay for an extra year as the chief resident, and you know what you're going to do? You're going to build a schedule. If you're really sophisticated, you have Excel, right? So when we first did this project, and I've now done this project with Boston University, I've done it with the Children's Hospital of Michigan, we've done it with 3 different, it's always the same. They build it by hand, because you know what? Doctors are really smart. They work, and I'm, I have enormous respect for our clinician collaborators. They work really hard, they're very smart, they can do this. And we have had a very hard time breaking through that barrier of, but there are these skills out there that you've never heard of. Right? There are these tools out there that could make this not only easier, and we started this thinking, instead of you spending 20 hours of your time, we'll build a tool and it will take a half hour of our time. What we didn't realize was the schedules would be better. And better schedules actually mean better patient safety and better educational training. So the chief sits down and they do this. How many of you know what a Sudoku is? Right? So Sudoku puzzles, you start drawing in numbers, and you're drawing in numbers, and you're drawing numbers, and at some point, I do Sudokus when the plane's going to take off and land. So I'm sitting on the plane yesterday, and I'm like, well, I can't work on my slides because of my laptop, so I've got my phone, and it's like this big, and I'm trying to read the numbers, and I go, I'm pretty smart too. I'm good at this stuff. How is it that I need to? I have no idea of how I messed this up, but I have 2. So you go, delete, 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 delete. You know what? I'm just going to read a book, right? So the more squares you fill in, the fewer choices you have, the less flexibility you have. You can make a mistake and not know it for a long, long, long time. And once you realize that there's a mistake, you don't know how far back to have to go. So typically what happens is one of 2 things. You realize you're at a corner where there's a slot left, and there's only one person who can fill that slot, and they're an intern, and they're not supposed to be there. And so you go, I'll put them in, right? You put them in, and you wait for hell to break loose when the attendings realize that they've got an intern in the morning and they don't like that. Or you start over, because you can't back up, so you throw it away. One of the things that fascinated me, the first time we did this, we did it with Boston University, they gave us all the rules. Actually, we spent months and months teasing out of them what the rules were. We got the rules, we built the schedule, we called them up, we were like, we have a schedule for you, and they said, and they cared about a couple of things. They didn't want to use moonlighters, they didn't want, well, let's stick with the example of interns working morning shifts, and they said, how many moonlighters did you end up using? And we said, well, you said we couldn't use moonlighters. And how many times did interns work the morning shift? Well, but you said we couldn't do that. The word constraint means you can't do that, right? There's probably a Latin thing behind it, but you can't do that. So if I write down an equation, the answer is not going to violate that equation. That's how this stuff works. And they said, ooh, it was like, oh, the lights came, it was really great. Okay, so it is very complex computationally. It is very time consuming. And so the main issue for them was they spent a huge amount of time to get a schedule that wasn't actually quite feasible. It wasn't completely legal. It's interesting, we have a paper that we did some analysis about sort of the quality of schedules, manually versus not, and the students were all upset because on a couple of the metrics by which you evaluate a schedule, we actually weren't doing a whole lot better. And they're sort of like, well, that doesn't look good. But the metric was equity. It was, you get 4 nights over the course of the month, you get 4 nights. It's pretty easy to enforce that goal when you're doing it by hand, because you go, Vikram, night, 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 check. Okay, Brian, night, 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 night. Okay, night. The hard part is when you start getting into complicated things like what I do on Monday has a relationship to what I do on Thursday, which impacts what I do the following Tuesday. And that's where it starts to get tricky to keep it in your head. Typically wouldn't get schedules that truly were in fact feasible. And in addition, you ran into all sorts of quality issues. And then the last piece surprised me, but one of the things that we discovered that the chief residents really liked is that it gave them some buffer. So I can say to you, so I'm chief resident and you're all of my residents, and remember, you're working really hard and you want Friday night off because your brother's going to be in town and you haven't seen him in a while, and you want to go to the Notre Dame, and you're getting married, and you all think that what you want is important, and you want these things, and I build a schedule, and I can't give all three of you what you want, and so you get to go to the Notre Dame game, and presumably root for Michigan, right? People get mad. They go to the chief resident, why do you like her better? Why did you give her a more desirable schedule? There's this perception that you're playing favorites. And so every now and then they would give us a set of information. We'd come back and we'd say, it's not feasible, I'm sorry. And they'd say, no, that's okay, because I can use you to say, with mathematical certainty, it doesn't exist, right? With mathematical certainty, it is not possible to achieve these things collectively. We have to make some compromises. Okay. So this is what I do, right? I mean, this you look at this and you sort of go, we gave a talk, one of my at like a biostatistics something. It was sort of a strange environment. I'm not quite sure why we were there. But somebody raised their hand and said, instead of integer programming, what other ideas did you try? What else would what other ways could you use to solve these problems? And the students laughed because they've never seen me speechless. And I was speechless, and I finally said, but what else would you do? I mean, you described this to me, and clearly this is integer programming. And I suppose we could have an argument about constraint programming and a few other things, but basically, this is integer programming, right? You've got a bunch of decisions that are related in some complicated way. You want to find a We're going to solve this as a mixed integer program, and I'm not going to get into too much of the detail, and we'll save that for the brown. I have a decision to make. And I think about my decisions in a slightly different way. I think about the entire world as being yes or no questions. So, does Vikrant work the first shift on Monday? Yes or no? Does Vikrant work the second shift on Monday? Yes or no? Does Reed work the third shift on Monday? Yes or no? And I have lots and lots and lots and lots of those questions. But now we can start to model these things mathematically. So if you look at this fancy thing in the middle, which is almost the only math I have, for every what is this? Shift. For every shift and for every day, I need a resident, right? I can write that out in words. For every shift of every day, I need exactly one resident. So for every shift, for every day, the number of residents equals 1. How do I count up the number of residents? Well, I lock that shift. I say, okay, let's think about the first shift on Monday the 7th. I lock that shift, I lock that res, and I say, are you working yes or no? 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 And I should say yes one time. That's all this is, right? It's really very, in some ways the docs look at us and they're like, that's it? And I say, yeah, but there are like hundreds of thousands of these. And they go, oh, okay, we're happy again. So sum over all residents, does this resident work that shift on that day? You got to have exactly 1. That mathematically forces that you've got coverage. You can have another shift that says, for this resident, on this shift, on this day, it has to equal 0 because that's part of their vacation. You can have things that say, this shift plus this shift has to equal at most 1, less than or equal to 1, because if I work this shift, then this shift doesn't give me enough rest. And so we can just take every one of those rules, and we can write these down as these simple linear equations. Okay? The good news if you're a resident, bad news if you're a PhD student, is solves, right? You write all these equations down, and you hit go. You plug it into Cplex. You don't tweak the parameters or anything else, and you get a feasible solution. And it's sort of fascinating. We've actually created, if anyone's interested, like for high school outreach, we're just wrapping up a game where we've created a simple data set, a subset of the rules, an Excel spreadsheet, where you can manually, you've got a half hour to build a schedule, and then you can hit a button and it will tell you everything that's actually illegal about your schedule, and then you can hit another button and it's not Excel Solver, it's Open Solver, but it's not even Cplex, using something very basic. In a nanosecond, it will give you a feasible schedule, just to get this notion that it's really hard to do by hand. It's really easy to do with integer programming. Okay? Doing okay. So here's what's interesting to me. So again, my PhD is basically in integer programming kinds of scheduling stuff. What's interesting to me is, now what do we do with this, right? I mean, there's no challenge. Sometimes you go and you hit go, and then it churns and churns and churns and churns for a long time. And so it's interesting to try and figure out an algorithm that's going to get a solution. Here, it's getting a solution. But what's a good solution? Before we did this with Boston University, they gave us all of the rules. We implemented the rules. We hit go. We went, oh, the angels sang and the clouds parted. And they were so excited. And then a nanosecond later, they went, wait a minute. This schedule's terrible. This is a terrible schedule. And I said, well, why? And they pointed out all sorts of things that they didn't like. And I said, you never told us any of that stuff, right? So we have made enormous progress that they can go from spending 20 hours to get a good schedule that breaks some of the rules to a bad schedule that satisfies all of the rules. So we're not there yet. So we want to build the optimal schedule, right? Because if you're in this field, you're an academic in operations research, you set your optimality gap, and that's what you're off to. The problem is, yes?
Is that the difference? Like, do they tell you the hard constraints and they constraints? I mean, is that the distinction?
No, they sometimes told us soft constraints sound like hard constraints. They sometimes didn't tell us hard constraints until we gave them a schedule. It's a combination of, and I'm being snarky, and I shouldn't, because the reality is, and this is the whole reason for our center, this is how I think, right? It's not it's not how one of my kids maybe, but I think about, like, what are the rules? And some of it is also so natural to them that it doesn't occur to them to say, you can't have an intern in the morning. Or, well, wait a minute, but if you're coming off of nights, then you can't do the first morning shift of your new rotation. So what would happen is, there were certain things that they told us, there were certain things that they didn't. I think the value, it really has to be this intense collaboration. You've got to find people who have become convinced that what you're doing will be worthwhile to them in the long run, to spend the time this back and forth, and that they trust you. So you say, look, I've learned to say, I'm going to give you a schedule, and I guarantee you're not going to like it. But it's really your fault, because you won't have told me everything I need to know, but I promise you I'm going to fix it. So rather than us spending a lot of time saying, are you sure you got everything? Are you sure you got everything? Is there anything you forgot? Just give me the things that jump off the top of your head. I'll build a schedule, and then you look at it, and you say, oh, but we can't do 2 back-to-back nights. Okay, then we'll implement that. I'll give you another schedule. Because when you see it, you'll know that it's wrong. People are really good at telling you what you don't like. So let me give you something, and you tell me what you don't like. Okay? So here's the non-mathematical challenge. There is no one clear objective function, right? When I do aviation work, we want to maximize profit or minimize cost. When I work in manufacturing, we want to maximize profit, or maybe we minimize cost. There is no cost here. The residents are funded by the Center for Medicare and Medicaid Services. There are sunk costs. There is no dollar, right? So we have all of these different things that they care about. There's equity. So how many shifts did you work? How many of those shifts were night shifts? Did you get the vacations that you asked for? There are these bad sleep patterns, so where you're coming back and forth between nights and days. You want to ramp up to nights. You don't want to kind of ramp back down. Post-continuity clinic call. You can technically work a night shift right after your afternoon clinic, but you don't want to, and we don't want you to if we can avoid it. All of this other stuff. So this is a multi-criteria objective function, and one of the ways that we deal with multi-criteria objective functions is we assign weights to normalize it, right? So if I care about the time it takes me to get to the airport and the amount of gas and the distance or something, I can normalize all of those in some way into common units. Basically, that's what weights do. You put in these trade-offs, and you solve it. The problem for us has been twofold. I'm going to do it backwards. One is, what we found is we can find feasible solutions really, 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 really fast. Really fast. When we put it in weights, sometimes it's still fast and sometimes it's really slow. Really slow, crawling slow. And slow is a problem when you're trying to elicit information from someone, right? If I sit down with the docs, and we sit down with them, it probably ends up being about twice a month. So in theory, it's a monthly schedule, but they're helping us with other things, so we probably sit down twice a month. When we could actually build a schedule, we show them a schedule, they say, I don't like this, we change something, we show them a schedule, I don't like this, we change something. You've got to have it fast. But the other problem is that the weights are really hard. So one of the things we created another game where I give you 5 weights, 5 criteria, excuse me, and you give me the mathematical weight. So what is it worth to you to have 1 extra night shift versus getting a vacation day, right? Is it a 10 to 1, 100 to 1, a 0.01 to 1? What is the ratio? You give me the weights, and we'll put those aside. Then I'm going to give you 10 schedules, and you tell me which is best. And then I'm going to take those 10 schedules, and I'm going to compute their objective under your weights. It never. The schedule that you like best is never the schedule that is the one that optimizes your weights. And so somebody had a really good idea, which was, what if you elicited those weights? So I'm going to give you schedules, and I'm going to watch to see an optimization problem to find the weights that maximize, blah, 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 which I really like as an academic. I think it's a great PhD topic, and we should probably do it. In this case, it would be a waste of time, because this month, we're launching EPIC. EPIC is our electronic health record. It is a huge challenge. I don't care about your wedding. You should not be getting married the month that we're launching EPIC. What were you thinking? I need only seniors, nobody gets vacation, every flex shift is covered, boom, 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 boom. We do that for 2 months. This month, everybody works so hard on EPIC, they're cracking. I need to make a priority that I give people their vacations. That's my priority. Then this month, I start getting hassled by the attendings because we're not covering enough flex shifts and they're yelling at me. So this month, we're making a priority. So even if I could elicit your preferences, they're going to change. And not only that, but they're nonlinear. Because I might be willing to give up 1 Friday night to get 1 extra good sleep pattern, but I wouldn't give up 5 to get 5. Okay? So what we have found to be surprisingly successful is the following. We're going to define metrics, so we've got each of these metrics that you care about. We generate a feasible schedule, and you look at it and you tell me what you don't like. And you say, boy, we've got a ton of post-continuity clinics. And I say, okay, we got 15 post-continuity clinics. I'm going to say a hard constraint, we can't have more than 5. Go. Now, it's still a feasibility problem, and it still typically solves pretty fast. And one of 2 things happens. We get a feasible solution or we don't. If we don't get a feasible solution, we know that, look, this month, you're going to have people. Sometimes you end up where this particular pool has lots of people who all have their continuity clinic on the same day of the week. Somebody has to work after their clinic. Okay? If it is feasible, then sometimes we tighten it even further, but more likely they say, oh, that's great, but in the process, now we've got a lot of bad sleep patterns, so let's tighten the bad sleep patterns. Okay? So we do this iterative back and forth, repeat until satisfied. Now, again, from a publication standpoint, that's really unsatisfying. In practice, that's what they want. They don't want optimal, right? They don't use the word optimal in the way that I use the word optimal. We frequently have clinicians say, I would like you to just make it a little more optimal. And for those of you engineers in the room, like your skin crawls, right? But what they mean is, I want something that gets the job done. I don't care about optimal. I wouldn't know optimal if I saw it. And the truth is, like buying a house, you show me 400 houses, I narrow it down to 4. I don't know which of the 4 I want. Right? I don't know what optimal is. We will frequently see that the chief will walk away with a schedule, and we're saying, but wait, I think we can get rid of 1 pattern. I have an idea to try, and he's like, yeah, it's good. Right? I got stuff to do, it's good. Okay? Or, I kind of don't like him anyway. He's a whiner, he's always getting out of things. If your program gave him a bad sleep pattern, it wasn't my choice, it's not my fault, I'm okay with that. Okay? So we repeat till satisfied. Okay, how are we doing? So our results thus far, it's fast. The whole process, typically it now takes them, I don't know if it takes them an hour to gather up all of the data files in terms of just putting the materials together, and they send it over to us. And then I have sort of a pool of students rotating through, so it's actually sort of for the new students, it's a good experience for a couple of months to build a schedule, so it's no big deal for them to spend some time doing it. And then we have a sit down. And we usually spend between an hour and a half in the sit down where we go, here's our schedule, what do you think? And he says, I would really like to give Mary that Friday night vacation, even if it means she's got to work a ton of extra weekends. And we tweak it, change something. What's really interesting is, first of all, we're learning from him. So we notice that he really looks at bad sleep patterns first. So let's prioritize bad sleep patterns before we give him the schedule. We've learned, actually he's learned, how we think about this. So he'll come in sometimes and say, okay, we have Christmas break, so Thanksgiving gets pre-scheduled, Christmas gets pre-scheduled, New Year's gets pre-scheduled. How are we going to handle that? And he starts to say things like, Well, if I already know that Rob has to work Thanksgiving, can I just pre-schedule that as though Rob were on, vacation and it's blocked out? Or a special thing where we're scheduling a longer period of time. I think the classic was we wanted to schedule something for just this time window. They're like, well, but here's another month that starts. Monday is the first day of the month, so we can just do that. So he's actually starting to think now when he brings us new things. He kind of knows, I need you to do this new thing, and I don't think it's going to be a big rule that says that emergency medicine can't work on Tuesdays. Well, if you can handle that pediatrics can't work on Thursdays, logically, it's probably the same thing, just a different name. But when I want to say that we've got 8 shifts instead of 7, I kind of get that you're writing code, and that's a big deal. Right? So it's been really interesting that he thinks about how he brings things to us differently. Okay? So I think I'm going to spend about 6 more minutes on slightly wonkier stuff, and just bear with me. And then I'm happy to do questions, and I can do wonky stuff after everybody else leaves, except the poor folks who actually want to do the wonky stuff. But one of the challenges is that we're still, to some extent, guiding the chief. We're still sort of saying, here's a schedule. We found, we're locally optimizing to some extent around the initial schedule that we present to him. So we've got one of my PhD students says, I just want to think more broadly about how can I kind of explore this space. So the challenge of multi-criteria optimization is that I, as the developer, I, as the engineer, can't tell you which you like better. So if I have a solution in aviation that costs $1 million, and I have a solution that costs $1.1 million, and I want to minimize cost, I can tell you that this one is better than that. If I have a schedule that has 10 post-continuity clinics, bad sleep patterns, and another one that has 12 post-continuity clinics, but only 1 bad sleep pattern, it's not my place to say which is the better solution. Right? You need to tell me that. But I do know that given my choice of 10 and 3 or 6 and 3, you'd rather 6 and 3. So Pareto is just talking about the idea that if I am as good or better in all categories, then it's a dominant solution, right? So what Young Che is looking at is to say, could I find some way, first of all, to make sure that any schedule that we give him is a Pareto dominant solution, right? Because if not, we could do better without him being in the room. And we should not be in a position where we give him something. We should be at the point where when he comes to work with us, and I think it's fascinating that actually he comes to us, which is really sort of a surprise to me in terms of this culture. When he comes to work with us, everything we give him should be the best we can possibly do without him contributing. Okay, so here we go. Here's my second slide with some equations. I have a linear integer program, so it's actually a binary. So x equals 0, 1 to the n. That just means I have n decisions. Right? So number of residents times number of shifts times number of days gives me n. Or in some general case, I've got a bunch of binary decisions and then some linear equations associated with them, and I have m objective functions. So these objective functions, these are the metrics. This is a function that says, f1x might say, how many post-continuity clinics do I have? How many times do you have to work an ED shift after your primary care clinic? The next one might be, how many bad sleep patterns are you working? The next one might be, how many vacation requests did we deny? I'm going to assume, to keep things easy, that all of our objective functions have integer coefficients, which in our case is true because we're just counting them. We're just saying how many. So in the simplest case, we can think about what he's calling. I have a feasible solution, and now all I have to do, because remember, we're really good at finding feasible solutions. I take my solution, and I add a constraint, and I say that the objective value of my new solution for metric 1 has to be at least as good as the current solution's value. So f1 of any solution x has to be at least as good as f1 of x1, my current solution in hand. And x2 has to be at least as good. And function 3 has to be. And then the last piece is the important piece, which says, and the sum of those, because I'm assuming integer coefficients, has to be strictly better. Now, in linear programming, we don't like strictly better because then you have boundary issues. But since I'm assuming integer coefficients, which it's less than 1, right? I subtract out 1. In theory, you could also just minimize this left-hand term, which in some cases is actually probably more effective, in some cases is slower, right? But the idea is you say, I have a solution, find me another solution, which is no worse in every criteria, and strictly better in at least one. And if I can clearly, I shouldn't have given the chiefs the first one, because this is clearly, given the 2, he would always pick the second one, right? And we can just iterate this until we can get the optimal solution. Okay? Blah, 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 blah. Okay, so the problem with this, not the problem, but the level of this is we've started with some seed. We've started with some random feasible solution, and then we've found the Pareto dominant solution relative to that. So what Young-Che's interest is, and Rob, we were talking a little bit about this sort of low-hanging fruit in healthcare versus sort of what's kind of consulting or just sort of master's level work versus research, and how do you fit this in? The sort of next step on that sort of PhD front is, even if we would never use it in practice, could you actually find the Pareto frontier? The entire set of Pareto dominant solutions, and then what would that buy you? So this is where I'm going to go really fast and at a very high level. I'm going to wave my hands a lot. But suppose that I have 2 metrics. Okay? So bad sleep patterns and post-continuity clinics are fine. I have 2 metrics. Pareto dominant set. What I can do is I can minimize relative to the first metric. Okay? So I can find what is the absolute minimum number of bad sleep patterns. Right? And it might mean that everything else is terrible, but what is the best I can do? And then I can separately say, now what is the absolute minimum number of post-continuity? What's the best I can do? So that's this point Z star. Z star 1 is the minimum value that you could possibly attain for metric 1. And Z star 2 is the best value you could attain for value 2. And so Z star is those 2 points, those 2 values. So what do? I then put in a constraint that says metric 1 can't exceed Z star of 1. Metric 2 can't exceed Z star of 2. Find me a feasible solution. And if it finds me a feasible solution, guess what? You have the optimal solution. We actually have a provably optimal solution that says you can't possibly do better in any criteria. In general, that tends not to happen because these metrics tend to be in conflict with each other, right? I mean, they inherently kind of conflict. The upper right-hand corner of this box, Z bar, says basically what I'm going to do is I'm going to go over to this right corner. Let me start with the right corner first. So I say, okay, I've got this lower left corner, and let's assume that that lower left corner is in fact infeasible. What I do is I say, okay, I'm going to fix metric 2 to be its best possible value. You can't exceed that. And I'm going to find the best solution for metric 1 relative to that value, right? So that's this point F1 of X. That says you can achieve that value for metric 1 subject to having the best possible value for metric 2. So it's basically the optimal value of metric 1 conditioned on the optimal value of metric 2. Right? That's that right corner. You can do the exact same thing in the other direction. So you can say, assuming that I get the optimal value for metric 1, what's the best I can possibly do for metric 2? And that's the corner. And if you fill out the box, right, that top right is the worst case scenario. And in fact, you would never hit that top right. Because if I was anywhere to the right of it, I could come in, reducing metric 1. If I was anywhere above it, I could come down, reducing metric 2. So my feasible, it's not a feasible region, my region of interest is now just this box. And so now what I can do is I can say, okay, point on the right corner. And what I want to do is say, so this is the best I can possibly do, assuming that my priority is metric 2. Assume that metric 1 has to be at least 1 unit better. So now I add a constraint that metric 1 can't exceed 1 unit better, and I find the best I can do for x2. And then I just keep pushing it over. So the thing to think about is if I say find a feasible solution, so right there I've got a solution where x1, where metric 1 is at f1, and I say, no, it's got to be at most f1 minus 1. It might be even less than that. Right? So you just keep shifting this over, and what you're basically saying is, if I care a little bit more about metric 1, what's the best you can do with metric 2? Okay, if I care a little bit more about metric 1, what's the best you can do with metric 2? And you can just sort of build this step, and you see that kind of example in the middle says, okay, when I go from the third bar to the second bar, I have to go up a little bit on metric 2, but once I go up a little bit on metric 2, that extra wiggle room lets me go even lower on metric 1. All right? And so these corner points are the only things that I actually have to show the chief resident. When you go up into 3 dimensions, it starts to get really ugly, and Young Che keeps drawing these pictures, and I keep standing on my head, and I can't think in 3 dimensions. The logic, you've got a condition on the condition. So you've got to fix one metric, and then you've got to find the optimal solution, so that's where you're shifting in. You're finding that optimal corner conditioned on that value, and then you keep stepping up and in and up and in and up and in. Okay, so that's all well and good. But at the end, the last thing that I want to talk about is the non-mathematics part, because to me, none of this matters if you can't implement it, right? So some of the key points here, it has been crucial that we have been engaged in the chief resident. And we are very lucky that the chief residents have all basically said, wow, this is a whole lot easier and a whole lot more interesting and a whole lot more rewarding than doing it by hand. What do you need from us, right? What do you need from us? We'll show up, we'll bring bagels, we'll bring cookies, we'll write letters for the students, we will let you come into the emergency department to observe so you can have some hands-on experience. What do you need from us? We have done other projects where the clinicians have not been as engaged, and because at the end of the day, I don't know what you want. You need to tell me what you want. You don't necessarily know what you want until you see what the options are, and we have to have this back and forth. Right? We have to have this recognition that there's stuff that I know that's useful to you, and there's stuff that you know that's useful to me, and if we don't work together on an extended period, we're not going to get anywhere. What's important about these collaborations is, so it's taken a good couple of years to really, really, really understand what's going on with this residency program. And now we've kind of got this tool, and Young Che will get a nice dissertation, he'll write some nice papers, and all of that's good. But if I have to start all over again with another clinical environment to learn that environment, now I've got another 3 years. One of the things that's happened with this is we have said, how come some months are really hard to schedule and some months are really easy? Well, that's because some months you have a whole bunch of interns, so they can't do the morning shift. And then the peds resident, or the family medicine people, family practice people, can't do Wednesdays. And then you get a bunch of peds residents with Tuesday clinics. So they can't do Wednesday morning because they've got to sleep because they work Tuesday night. Well, how come some months you've got a ton of those people and some months you don't? Because when they built the block schedule, which says you're in HEMONC in January, you're in NICU in January, you're in the peds emergency department in January, they can't factor in that level of subtlety. So guess what we did this year? The block schedule, right? So that relationship allows us to see and allows them to say, hey, I have another problem that I just assumed I was stuck with, but I kind of think maybe you guys could help. So we've learned from them, they've learned from us. We have changed the way we think about problems. They have changed the way that they think about problems. And so a huge part of my focus now is how do we facilitate this? How do we fund it? How do we support students so that undergraduates can get involved in this and have really good learning experiences and go out and work in the healthcare environment at a very junior level. And at the same time, our PhD students can get really good methodological experience. How do we get this valued in the community? How do we bring these groups of people together so that it's valued? I'm on time. That's never happened, Vikrant. Thank you very much. All right, I'm happy to take questions as we have time. Yeah, was that a stretch? There was a stretch somewhere. Okay, go ahead.
You seem to focus your energy and capacity on the umbrella of residency training and the in-program process that goes on within that dynamic. Have you applied the tools to the question of patient scheduling in the outpatient arena?
So one of the projects we're working on is in endocrinology, and it's interesting. I think it's a really good example of this challenge we face, which is sometimes it's not really sophisticated math programming that's needed. So in this particular endocrinology clinic, so endocrinology involves metabolism, diabetes, weight kinds of issues, and there's an endocrinologist who's developed her research is in weight loss for the morbidly obese. So she's developed a particular program. She's gotten research funding from NIH. She's gotten funding from Blue Cross Blue Shield to actually support this. And the idea is you come in, you have an extensive workup, you're on like 200 for 2 weeks, and then boom, 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 boom. And it's really tied in with stuff that goes on in your metabolism in terms of how your body processes signals that you get from the amount of calories and so on. Her problem is we got a busy practice. So the protocol says you get seen for a 45-minute visit. 3 weeks later, you need a 15-minute return visit. 3 weeks later, a 15-minute return. 3 weeks later, 15 return. Then 6 weeks, 6 weeks, 6 weeks. And so part of what, and her problem is we bring people in, we can't get them an appointment forever. And if you're dealing with someone who's made the difficult decision that they're going to these are radical life changes to deal with their health issue, and you say, great, good for you, and I'll see you in 3 months, you lose things, right? So she says, I can't get patients in. And when I do get patients in, they come in, they have their first visit, and then instead of coming back in 3 weeks for their second visit, I can't book them for 5 weeks out. So what we've done, it's kind of neat actually, it's not an optimization thing, but we've developed a database where I get every day the year out schedule. And so what we've got is this layering where we can see you made an appointment on this day, and then a week later I can see that you canceled and rescheduled that appointment, and then a week later I can see that something else happened, that the first appointment got refilled, and so on. And so it's pretty simple, some of the stuff that we're seeing. For example, they don't manage their WAIT list, their wait list, in the sense that you call up and you want an appointment and I book you for 6 months out, and then 3 months later you call up and I say, you're in luck, somebody canceled this morning, I can see you tomorrow. So there's an equity issue there. That's one. The second is, if they're booking about 6 weeks out, then I book you for your first appointment and there's not a second appointment in the 3-week window. So you're set up to fail. The third challenge is, so ideally I shouldn't be booking you unless not only do I have your first appointment, but I have your second appointment. And then what they're doing is they're not actually booking 2 appointments. So I look and I say, okay, there's an appointment on March 1st and there's an appointment on March 26th. Beautiful, I book you for March 1st. On March 1st, March 26th isn't available anymore. So even helping them to understand, and a lot of it is, I need data in front of me to convince somebody else to make the change. So they say, we kind of know this, but we have to see the data. What's interesting to me about patient versus attending is patient tends to be rolling. A different, in some ways more interesting mathematics. Because when I schedule providers, I sit down now, I have all the information in front of me, and in one shot, I build a period of time. You call up and you make an appointment, and I give you an appointment, and then you call up and you make an appointment, and I have to make a decision about what's left in the capacity. We have another student who's working in chemotherapy with the Cancer Center, and what he's looking at is, what should the appointment durations be? So right now, the Cancer Center says, you 10 people all have the same protocol, so you're all a 2-hour appointment. And the reality is, you should be, some of the simplifications, like in the middle of the day, you have more buffer, and then it slacks off again. It's funny, we saw some of the stuff, I looked at it, I was like, where have I seen that? Where have I seen that? Where have I seen that? You see the same thing in aviation. You build the buffer up. Buffer in the morning is great to keep the day on track, except you've got a lower probability of needing it, and then you've wasted the capacity. So he's looking at the sort of stochastic, the randomness in treatment times. But the patient scheduling problem, there's just so much opportunity there. Yeah. Yes?
So I'm thinking from a commercializable sort of standpoint. You said it is really program specific. How generalizable do you think this is, both in terms of when you get a new chief every year, and how much do their preferences change? Maybe their experience first, second, third-year resident really shape how they feel scheduling should be done.
So I think we've done a reasonably good job of developing this particular tool so that when one chief's preferences are different than another, that's okay, because the whole mechanism is designed around you maneuvering towards your preferences. So that part I think is okay. The challenge of, if we then went to a pediatric emergency department at Dartmouth, part of what I think is, again, now an interesting research question is, and maybe it's more of a computer science question than it is an OR question, can I design something that's flexible enough that by just changing parameters, so for example, we have 7 overlapping shifts. I don't think it would be all that difficult for me to say, oh, this program has 8 shifts, and to have the code set up and to have the algorithm set up such that it recognized, okay, so there's different overlaps and there are different 8-hour or 10-hour sleep rules, but you could do that. So I think you can start to layer, And the challenge is when you get too general, then the amount, I mean, in the most general case, you say, you just give me your A matrix, right? You give me your A matrix, and I can solve any problem. But the amount of work to actually create the input file is enormous. And where you see commercial stuff, there's a little bit of commercial stuff on the market, and most of it, that I've seen at least, isn't very successful because it is so prescriptive. You tell me, everybody works, every fourth day. Just tell me the order of the 4 people, and I'll plug it in, and I've built your schedule. So we're spending a lot of time thinking about, can you make this, I think maybe a better example is the block scheduling. So we did 2 block schedules. So block schedule is, you're going to do this for a month, this for a month, this for a month. For peds, and we did it for surgery. And we actually did it as 2 separate projects, and one of this year's goals is to say, could we actually convert it into one single program whereby just changing your input files both could apply. So conceptually, I've got a year, I've got a group of people, each person's from a program, each rotation or each service has a requirement. Like 95% of it's probably the same. Probably sort of the model of, I know I have a good friend who worked for Oracle for years, and his job was basically, you come in as a consultant, and I spend 3 months to fit what you need, right? And so it was pretty sophisticated stuff, and I think similarly it may be, and I have to actually write a few more constraints for you, right? But the guts of it, the variable definition, the interface, I think maybe you could do. But yeah. And this goes back to the widget thing, right? When you go in and you say, well, we can't handle the fact that your emergency medicine people do conference on Wednesdays. Goodbye, right? What's the point? You're no good to me. Yeah?
What's the difference with the airline crew scheduling and the resident scheduling?
What's the difference?
Yes.
So I think there are a lot of similarities. I think one of the biggest differences is crew scheduling has this continuity component. So if you think about a pilot starts in Detroit, flies to Boston. From Boston, they fly to Chicago. From Chicago to Los Angeles. They spend the night at a hotel. They get up, they fly to Salt Lake City, etc. And so you've got to have these connections in a way that you don't, I can think a little bit more discreetly about, I assign you to this time, and to this time, and to this time. And there's some, although it would be interesting, so one of the things that Young Che is trying to do is to actually build a version of this model that basically looks like column generation. So could my variables be an entire schedule for a resident? I mean, really, that's what you do when you schedule crew scheduling. You build entire rotations for individual pilots, and then you say, it's just pick sets such that every flight is covered. So you could build an entire month-long schedule for a resident as a variable, and then just pick those such that you had coverage. And my initial thought when he suggested it was, you're a PhD program who's got a hammer and you want to use this as your nail. But I think it is actually kind of interesting because there is some notion of a network, right? If I work Monday morning from 7 a.m. to 5 p.m., then I can't start another shift until at least 7 a.m. the next morning, right? So you could actually think about some sort of a time-space network. One of the other things that makes crew scheduling really complicated is this very, very messy cost function,
Yes.
right? So that messy nonlinear cost function sort of forces you to have the notion of a duty and the notion of a pairing, and we're lucky that we don't have those.
Yeah. I think for the crew scheduling program, they always to minimize the total cost, and they always don't care about just like the pilot satisfaction or whether they're satisfied. Okay.
Well, I think the fact that it's multi-criteria is another big difference that makes certain things easier.
So what's
Yeah.
the difference? Just like there is, it's really hard to schedule just like to make sure whether the residents are satisfied or not. Just like we just to make sure that all the patients, all the residents, they must be legally and to work just 5 days a week or not so many hours per day. But it's really hard to schedule that. Okay, many people have their reason to choose their optimal solution.
Yeah. So I think at some level, they're fundamental. I think at some level they're just really, really different problems. And it's sort of interesting to see how you can apply some methodology, but at some core, it's sort of like saying what's the difference between and, machine shop scheduling, right? They're just components of them that are really different. Yeah. Okay.
So I guess we're pretty much out of time. So
Great.
let me thank Professor Cohn
Great.
for a very nice.
Thank you very much.